Another spine webinar. You may recall our last spine webinar was about the subaxial spine, and today we're going to be talking about the occipito-cervical junction and the upper cervical spine. Fusion techniques, decompressions, and tricks and tips from all the experts. So to start, we will have Dr. Sundar, who will talk about the anatomy and biomechanics of this region by way of introduction for this topic today.
Good evening, everyone. I would like to thank the Australasian Society of Neurological Surgeons, as well as Dr. Tanya Yuen for giving me this wonderful opportunity. I'm very grateful to present in front of all the senior professors from different countries. I'll be talking about the anatomy and biomechanics of the surgery of occipito-cervical junction. I'm Sundarakrishnan Dharanipathy, and I'm a neurosurgeon from India, currently doing a spine fellowship at St. Vincent's Hospital, Melbourne. A brief introduction into the topic. The craniovertebral junction, as we all know, is composed of occiput, atlas, axis, and a lot of numerous ligaments. It is a complex structure and it contains the vital neural and vascular structures. It represents the transition point between the brain and spine, and majority of spine's rotation, flexion, and extension occur here. Understanding the embryology, the complex anatomy, and biomechanics is key for effective evaluation and treatment of various pathological processes. I'll be dealing in three subheadings: the embryology, the anatomy proper, and the biomechanics. Starting from the embryology, we all know the embryology basics. Between third to fifth week of intrauterine life, the neural tube will be formed. Once the neural tube is formed, the mesoderm surrounding the neural tube forms the somites. We have 42 somites from 42 sclerotomes. The first four sclerotomes are the occipital sclerotomes, which forms the basic occiput and the proatlas. The first and second spinal sclerotome forms the atlas and axis. Here is another summary of the formation of various bony landmarks of the craniovertebral junction. Each sclerotome divides into hypocentrum, centrum, and neural arch and gives rise to various bony structures. This diagram summarizes the embryology in brief. The key takeaways here are: atlas is a transitional vertebra. The reason is the centrum that is supposed to form the body of atlas actually forms the dens and fuses with the axis vertebra. And the odontoid process of axis develops from all three sclerotomes, the proatlas, first and second spinal sclerotome. Some of the usual variants and anomalies in this location: os odontoideum is nothing but persistence of cartilage after 8 years of age, commonly confused with an unrecognized structure. If it causes instability, it causes neurological compression and it causes problem. Ossiculum terminale, also called as Bergman's ossicle, is a normal variant and doesn't cause problem. Platybasia is abnormal flattening of the skull base with base of skull angle more than 143 degrees. We have basilar invagination, which is nothing but cephalate protrusion of the tip of odontoid. We have two types of BI, primary and secondary BI, and multiple topographic types within them. It is commonly associated with vertebral artery anomalies. Klippel-Feil syndrome is nothing but a problem in resegmentation. Bicornate dens is a very rare anomaly where there is a problem in the formation of the ossification of tip of basal dens. Coming to my next subdivision, the anatomy. I will start with the bony anatomy. The first bone is the occiput. The occiput forms the majority of the foramen magnum. Foramen magnum is around 3 centimeters in diameter and transmits all the neural structures. Anterior to the foramen magnum, the anterior margin of the foramen magnum is the basic occiput, which is the lower portion of the clivus. Anterolaterally, we have the large occipital condyles, and posteriorly, we have the rest of the occipital bone as well as the opisthion. The second bone is atlas. Atlas is a transitional vertebra. It has anterior and posterior arch. Posterior arch is longer than the anterior arch. It has paired lateral masses with superior and inferior facets. It also has paired transverse process. The transverse process of atlas is considerably bigger than the transverse process of other cervical vertebra, and it contains the foramen transversorium, which transmits the vertebral artery. We can also see the tubercle that gives attachment to the transverse atlantal ligament. The third bone is the axis. Axis, the most important variant or the structure in axis is the odontoid process. As we saw earlier, it forms from all three sclerotomes and it articulates with the atlas vertebra. Apart from the odontoid process, it has a body, a paired lateral mass, two pedicles, as well as transverse process. The posterior elements include the lamina and thick spinous process due to the stronger muscles getting attached to the spinous process. Going into the joint anatomy, the occipito-atlantal joint, as we see here, the occipito-atlantal joint is a condyloid synovial joint. The convex occipital condyles articulate with the cup-shaped superior facet of atlas to form this condyloid joint. The second joint is between the atlas and the axis. Actually, we have a median atlantodental joint and lateral facet joints. The facet joints of atlantoaxial system is really important because they are horizontal and they are really flat. This in turn permits the rotation against the pivot. The pivot is formed by the dents and hence the axial rotation takes place at this region. Going to the ligaments, we can see ligaments under three categories. The ligaments between OC1. There are three important ligaments: anterior atlanto-occipital membrane, which is nothing but continuation of the ALL and extends from the tip of foramen magnum to the tip of anterior atlantal arch. Posterior atlanto-occipital membrane lies posterior. It arises from the posterior margin of foramen magnum till the posterior arch. And the third ligament is the cruciate ligament, the ascending band of the cruciate ligament. So all these three ligaments, they connect the atlas bone to the occipital bone. The second set of ligaments between occipit and C2. We have the tectorial membrane. Tectorial membrane has two parts. The superficial part continues with the posterior longitudinal ligament here, and the deep part, it fans out laterally and goes and attaches to the occipital condyle. The second ligament is the alar ligament, which is also a check ligament, and it has two parts. The occipito-alar portion connects C2 with the occipital condyle. The third ligament, which is of less significance, is the apical ligament. Now, ligaments between is the transverse atlantoaxial ligament. It is one of the strongest, has a strap-like mechanism and keeps the odontoid process within the notch of atlas. The second ligament is the atlanto-alar portion of the alar ligament, and the third one is the descending band of the cruciate ligament itself. So how do we assess the integrity of TAL? We follow the Spence rule, which is nothing but in an open mouth odontoid X-ray, we calculate the overhang of C1 lateral mass over the lateral mass of C2. If it is more than 6.9 mm, then it indicates that TAL integrity is lost. Also, increased atlantodental interval indicates a loss of integrity of TAL. The arterial anatomy. Vertebral artery gives rise to anterior and posterior ascending arteries. They supply axis vertebra. Then they further ascend, they form an arterial arcade called apical odontoid arcade, which also gets reinforcement from occipital artery. Together, they supply the occipito-C1 junction. Apart from the normal anatomy, the abnormal anatomy, which is quite common, is really important from a surgical perspective. High riding vertebral artery, which is nothing but an isthmus less than 5 mm, is really important, and we have to consider this abnormal variant before consideration of fixation. Persistent FIA, which is nothing but first intrasegmental artery, is another variant which is present in 3% of normal angiograms. This is nothing but the embryological artery persists and it enters the dura between C1 and C2. The normal vertebral artery pierces the dura between OC1, whereas this artery enters between C1 and C2. Extradural origin of pica is seen in 1 to 1.5% of normal population. Pica that arises very low and extradurally. And the third less common variant is a fenestrated vertebral artery. The vertebral artery divides into two branches which unites again and then pierces the dura. It is commonly associated with aneurysms and other vascular malformations. Going into the biomechanics, this region has unique anatomy. The reason being weight bearing as well as movements happen through the joints. In the rest of the spinal column, weight bearing happens in the intervertebral disc also, which is lacking here. Flexion and extension, axial rotation and lateral bending are the major movements. Translation, distraction, and compression, they are minimal or nil because of the stability from ligamentous and osseous structures. We can consider biomechanics in two parts. Occipito-C1 joint. There are three movements. As we see here, the primary movement is flexion extension. The mean movement is 23 to 24.5 degrees. Further flexion is limited by the tip of dent striking against the foramen magnum, and further extension is limited by the tectorial membrane. The second movement that happens at this joint is the axial rotation, which is around 2.4 to 7.2 degrees. It is resisted by the structures of the occipito-C1 joint itself and by the alar ligaments. The third minor movement at this joint is the lateral bending movement, which is around 3.4 to 5.5 degrees and restricted by the occipital condyles. So biomechanics of the atlantoaxial joint. Again, three different movements. The primary movement is axial rotation because of the pivot formed by odontoid. The mean axial rotation is 23.3 to 38.9 degrees, and axial rotation any further is limited by the structure and alignment of the C1, C2 joint itself, ipsilateral tal and contralateral alar ligament. All these structures work together to limit any further axial rotation. Axial rotation greater than 30 degrees is associated with stretching and kinking of contralateral vertebral artery, and axial rotation greater than 45 degree can occlude ipsilateral vertebral artery. The second minor movement is flexion extension, which is 10.1 to 22.4 degrees, and it is limited by tal and tectorial membrane, respectively. Lateral bending is again a minor movement here, which is around 6.7 degrees and limited by the alar ligaments. When movements go supraphysiological, injury happens and they do have their biomechanics. If you look here, a vertical compression force, a neutrally aligned compression force from the top, it can fracture the bones. It can cause 4-part C1 fracture, which is nothing but the Jefferson's fracture. It can also cause stable and unstable occipital condyle fractures. A vertical force, which is posteriorly positioned like this, can cause posterior ring of C1 fracture near the vertebral artery. Significant bending force, particularly extension with a distraction injury, it can cause hangman's fracture, which is usually associated with C1 arch fractures. Type 1 to 3 odontoid fractures, they happen as a result of injury vectors at various angles, like 90 degrees, 45 degrees, and sagittal. And this injury can occur from any direction and they can produce odontoid fractures. Anterior directed translation injury, like it happens after the tal is damaged and the anterior translation happens. And if there is the injury vector has a significant torque component, it can damage the alar ligaments. Remember, like the alar ligaments like help provide stability with limits further rotation. So once they get damaged, it can cause rotatory subluxation. So these are the pictures or examples like to show how a supraphysiological movement can affect biomechanics and can cause damage to the structures. So to summarize my presentation, like the complex anatomy of the craniovertebral junction is really important. We need to know the anatomy. We need to remember the biomechanics and the movements, and radiological image, the angiogram is extremely important before going into the surgical decision making. Thank you.
Thank you, Dr. Sundar. We might keep questions to the end, just for timing purposes. Dr. Goel is not quite online yet, so we might go to Professor Joaquim. He is Professor of Neurosurgery and Head of Spine at the University of Campinas in Sao Paulo, Brazil. He's a member of the steering committee, AO Spine Knowledge Forum, Trauma and Infection, and is an active contributor to the AO Spine LANTAM projects. He's co-authored over 100 peer-reviewed papers and book chapters. His total citations exceed 4,900. He's going to be talking about the anterior approaches to the occipitocervical and upper cervical spine region. And thank you, Professor. I think you have to unmute, Professor.
Sorry, so thank you so much for the invitation. Thank you, Tanya, for the presentation. It's a great opportunity to talk about craniocervical junction. It's something I really like. I share my presentation in two parts. I'm going to start with anterior odontoid screw fixation. If you have some connective issues, please let me know. All this presentation content, it's mostly based on this article, and it's free. Surgical treatment of type 2 when you choose anterior versus posterior fusion. What we know about odontoid fractures, that they are pretty common, especially in older patients with osteoporosis or poor bone stocks. And despite the new classifications, we still use an Anderson and Alonso classification because it's pretty simple, it's comprehensive, and every resident and fellow know what it's a type 2 Anderson-Alonso classification. So we share type 1 when it's above the transverse ligament, type 2 in the base of the dents, and when affects the body of the C2, we said it's a type 3. And we have three treatment options. Non-operative, mostly based on cervical collar, and some places still using a halo, but halo, there is some morbidity, and most of at least in the Western countries, we don't use too much anymore, just in a few very selected cases. And operative, an anterior approach or a posterior approach. The anterior approach, it's an osteosynthesis that it's made with anterior odontoid screw fixation. And while we try to fix these patients, because the rate of pseudoarthrosis is pretty high. So if you have factors of pseudoarthrosis such as age, this you can find 60 or 50 years old. Type 2, what's a type 2A? It's when you have a severe comminution at the dent's base, because the chance of healing is pretty bad. And if you have a gap between the fragments, a dislocated fragments, and patients who are heavy smokers, they are risk factors for a non-successful non-operative treatment. This patient, it's interesting. It is safe. This patient, it's a young patient, don't want surgery, and he have a very good healing. So it's possible to treat non-operative. Is not my preference option. I'm going to tell about that, but it's a safe and a really good option to treat. But the focus of this presentation, it's what's the difference between an anterior and a posterior approach, when I have to choose one versus another. This is a very, very recent meta-analysis that shows in a large group of patients that a posterior approach, the chance of fusion is higher, and the chance of reoperation is higher. So what I usually say that you can use a posterior approach for all odontoid fractures, and the patients that you're going to use an anterior odontoid screw fixation. That's the main difference. Okay, I decide to operate it on. So if I want to do a posterior approach, okay, it's okay for everyone. But if I have to look at for anterior odontoid screw, I have to choose better my patients. And what are the options, the surgical options? Anterior approach, you can use 1 or 2 screws. And the posterior approach, we don't recommend it to use wire anymore because it's a semi-rigid fixation and there's a right risk for failure. And most of the times we use the Goel technique, C1, C2 fusion. It's not harms technique. Goel, Professor can defend him, it's a Goel technique, or the transarticular screw fixation. They are rigid fixations and they are the options for a posterior approach. The indications for here is the Roy-Camille classification. In this morphology, I don't know if you can see my mouse, but you can see the red. It's a contraindication for the screw because the screw enters in the gap. So all the others morphologies here, B, C, and D, you can put a screw, but in this one that there's a red arrow, you cannot because the screw can enter in the gap. So it's a relative contraindication. The fracture must be aligned. If it's not aligned, it's better to go posterior. Of course, you can try to reduce it intraoperatively. You can use your finger or like a forceps to manipulate the craniocervical junction and align the odontoid fragment. But if the fragment is not aligned, maybe it's better to choose a posterior approach because once it's a primary osteosynthesis, you need to have a very good alignment. But there are contraindications. Patients with severe osteoporosis, as I shown, has once the odontoid screw is not so strong, it's a relative contraindications for anterior odontoid screw. The ligamentous injury, if you have a ligamentous injury, it's safe to go posteriorly, and you can see if you have a ligamentous injury, checking your MRI, or even if you have an associated lateral mass fracture with displacement of the C1, so it's better to go posterior. And if you have severe cervical thoracic kyphosis, I'm going to show why this is a contraindication. This is a patient, old patient. You see he has a very high T1 slope. So you cannot have angle to put an odontoid screw in a patient with a severe cervical thoracic kyphosis. So this is another relative contraindications for anterior odontoid screw fixation. And is there any difference between 1 or 2 screws? There is some retrospective studies that shows that 2 screws are slightly better than 1 screws. This is not really true, and it's not 100% sure that you have to put 2 screws. In my opinion, if you can put 2, it's okay, but that doesn't increase too much the chance of fusion. You have to make sure that the patient doesn't have dysphagia because anterior approach has a high rate of dysphagia. So if you have a very old patient that already have swallowing problems, maybe I would recommend you not to choose the anterior approach. You prefer to go posterior approach. The technique is basically to put a wire in the odontoid and then you use a cannulated screws. I like to measure the screw before on the CT, and you have to measure intraoperatively so you have already an idea of the size of your screws. But if I have to give a message to the fellows and residents, you have to have 2 fluoroscopic. If you don't have biplanar fluoroscopy, don't do an anterior odontoid because it's a very simple procedure. But if you have biplanar fluoroscopy, this is the way I put one fluoroscopic device like this and the other in AP. So you have AP and lateral in real time. The cervical approach is unusual and common Smith-Robinson approach. Here's a young patient with good bone stock and with a screw. most of the times you have to do like a roll in the inferior part of C2 to accommodate the head of your screw. Here is another patient. Take a look at the biplanar. I'm going to put this picture to see how can you put the fluoroscopy, and you have to make sure you have a good AP vision. If you don't have a good AP vision, you have to move the head of your patient. You have to adjust the neck. In this case, I put 2 screws because it was an osteoporotic patient. It's difficult to put 2 screws. If you have biplanar fluoroscopy, it's not so difficult. Just take a little bit more planning. And the intraoperatively, what you have to make sure that you don't advance it too much. Of course, the wire, and you have to put a right size screw. Of course, what is this? This is a C1, C2 odontoid fracture. If you reduce this, you have ligamentous injury. This is not for anterior screw. You have not to consider, oh, I'm going to put a traction, reduce, and put an anterior odontoid screw. No, this is not indicated because you have a severe ligamentous injury, so you have to go posterior. This is another case. I'm going to show some case that anterior, you have odontoid screw, but you have ligamentous injuries. And this is a very specific scenario. This patient has 91 years old. I tried to do non-operative, but he cannot stand in the pain. It was a very healthy old lady. And I don't do anterior because she was stiff and have osteoporosis. So, of course, the posterior approach is a little bit more morbid, but we prefer than a failure, because if you failure, you have to come back. And you have ligamentous injury, you cannot do anterior odontoid screw. You have to reduce traction and do posterior. This is a very important point when you choose anterior versus posterior. So basically, in this table, what is the difference between anterior and posterior? You preserve motion. When you do anterior odontoid screw, you preserve motion because C1, C2, it's not fused. And we go posterior, you stop motion, so rotation it's affected. Anterior is safe and it's less bloody and it's fast. Posterior, most of the times you require bone graft and you have some risk of vertebral artery injury. It's a little bit more demanding and the operative time and blood loss is higher in posterior approach than anterior. But posterior is not limited by the fracture morphology, not the body habitus. You can have kyphosis, you don't need to have kyphosis, you can have ankylosing, and you can go posterior. And a very important point is that old fractures are a contraindication for anterior odontoid screw fixation. Why? Most of the times, if you do a primary osteosynthesis, but you have already some pseudoarthrosis or some fibrous tissues in the fragments and the body, it doesn't fix. So if you have fractures that have 3 to 6 months, it's better to choose the posterior approach, even if you have a good morphology. And the risk of dysphagia is higher in anterior approach compared with posterior approach. In conclusion, type 2, you have a high rates of non-healing with non-operative management. That's why surgery can be an indication if the patient is not frail. So if I indicated surgery, the patient able to have surgery. What I usually do, if I have a favorite fracture line and the patient have good bone stock, today my preference is anterior odontoid screw fixation. If the patient, I decide for surgery and the patient has some fracture disalignment or it's a very old patient, most of the times I try to do posterior. Each approach has advantages and disadvantages, and surgeon should know which one is better for your patient. You have to have your own experience, and anterior surgery is fast and have excellent results, but you have to select it well your patients. And biplanar fluoroscopy is imperative if you want to have a very good result. Thank you very much for this honor. Tanya, should I stop it for questions or can I go on and talk about odontodectomy?
Please go on, Professor. That was
Okay.
great. Thank you. We'll do questions at the end.
Sure, I'll be happy to answer. So this is the second presentation. It's about odontoidectomy. All this presentation is in this on this article that we published with Dr. Dan Rio. It's about transoral endoscopic. Odontoidectomy, it's not so common nowadays because the powerful of posterior fixations and understanding of how to align in the cervical, craniocervical junction, most of the times we can reduce that using posterior approach, but we still have indications. And the most commons are panels, inflammatory panels, most of the rheumatoid arteries, or some arthritis, even with not associated with rheumatoid, and basilar invagulation that we cannot reduce. So these are the most common indications. As I said, we reduce the use of this technique nowadays because of the powerful of posterior techniques and the powerful of the medications to treat rheumatoid arthritis. And when I started in my division, I have a lot of panels. Nowadays, I don't have because of the biologics used in rheumatoid arthritis. So it's something that I really have this perception that this improves the treatment of rheumatoid arthritis. We have less involvement of the craniocervical junction. What are the indications to do that? It's when you still have a ventral compression after a failed posterior surgery. That's my common indication nowadays. If I don't do a very good job or I cannot do a very good job on the posterior approach, I try to do it anteriorly. There are others that you can do anterior release, and you can use a plate to reduce the basilar invagination, but it's not my experience. I always prefer posterior approach and use anterior in case of failure. But just to let know that there's options of to reduce from anterior and to put a plate from the mouth. What are the contraindications? Of course, they are most of relative, but you have to make sure that I usually say that a dentist should look at the mouth of your patient to make sure that there is no infection, there's no problem in the oropharynx, and the dental condition should be at least good. You have to make sure that you don't have a vascular anomaly in the midline, and the height of the odontoid, it dictates if you go to the mouth or if you go to the nose. It's important. You have to consider how much the patient can open the mouth. If he cannot open the mouth, it's difficult to do a transoral. If you have some ankylosis in the temporomandibular joint. And our preference nowadays is for endoscopic endonasal procedures because they are less morbid. I do this with the school-based team. I just do spinal surgery. I don't do cranial. And so when I have to take out odontoid, I go with the school-based. They come with me together. And as I said, there's two routes, the transoral and endonasal. And you can go open or endoscopy for the transoral, and the endonasal is 100% endoscopic. I'm not gonna not talk about the craniocervical junction because Professor Sundarakrishnan talked in a perfect way about anatomy, but just to make sure, it's a very complex region that most of the flexion is occipital C1 and rotation is C1, C2. So you have a lot of movement between these joints. And before we started this surgery, it's mandatory to have a CT scan with sagittal, coronal, and axial cuts, an MRI of the brain and the cervical, and most of the times I don't get a CT angiogram anymore. I usually see the vertebral in the MRI, and if it's abnormal, then I get the CT angiogram. And this is our protocol. I look at for the vertebral artery, okay, it's a normal position, no congenital malformation, I don't need a CT angiogram. Oh, I get a CT angiogram. And dynamic exams, I usually have CT or MRI in flexion extension, most for research, and in cases where there's some questions about stability. Nowadays, it's pretty easy because you have fibroscopy for airway, but you have to make sure these patients have a very experienced anesthesiologist In the past, I have some problems with the airway because most of these patients have small jaws and they have a difficult airway access. Of course, multimodal monitoring is necessary. We have, especially in the position of the patient, I would recommend the monitoring before you started the anesthesiologist, and then when you flip the patient. And it's important to have the position of the patient to make sure that you don't flex or extend too much the neck. A very important concept that is basically based on anatomic studies is that when you remove the odontoid and the transverse ligament, you have some increased range of motion. So you have to consider that after odontoidectomy, the craniocervical junction is unstable. So after any resection, you have to consider a fixation. And here's a diagram that how to choose. If you have a higher level of pathology, then you use endoscopic endonasal. If you have a lower, you can go transcervical or even transoral. Here is in red, you can see the limited of the approach of each technique. The patient will clean the mouth with proper antibiotics and drapes around the mouth. Some mild extension is recommended if possible, and we try nowadays to do this with navigation to make sure that we are in the midline and we remove everything. We don't use a lumbar drain except for some chordomas or some very reconstructive cases, but it's not common to put a lumbar drain. For oral surgery, we asked for a nasal intubation, and it gives you some space. And for endoscopic endonasal, a oral tube. And if you do a transoral approach, most of these patients are not extubated immediately because you have some tongue swelling. So we generally let this patient 1 or 2 days in the ICU before extubation to decrease the swelling. There is a bunch of retractors in the market. We have this, the ENT team use this one in our institution. For transoral, we don't cut the palate. What we do, we use this, the nasogastric tube, and we suture in the palate, and we pull the nasogastric tube, and the palate goes high. And we cut in the midline, started removing the anterior transverse. We can palpate it. If you don't have navigation, you can palpate it. Then you use the fluoroscopy to make sure that you have the anterior arch of C1. We remove the arch of C1. We then remove the odontoid from inside and then from the upper part to the bottom, because to avoid that the apical ligament take the dens high. And here we discuss some case. This is a 2 years old with this malignant tumor in the clivus. We did a endoscopic transoral biopsy. This was just a biopsy, a standard biopsy, and then we flip the child and fix it with a laminar screw because it's too small, and the C1 lateral mass and the condyles were completely destroyed. And this is a case that comes to my institution. The patient has a failure occipital-cervical fusion. We have 2 options: to remove the fusion from behind and realignment, or just do anterior decompression. That's a case that we prefer to go anterior than to remove, because in the notes of the surgeon that operated him, he has a vertebral artery injury in the first surgery. So we decided that anterior was safer than come back and remove everything. And we did anterior decompression because she has an incomplete decompression. This was another patient that was already fixed in our neighbor hospital here, a non-university hospital, and comes to us. And she had persistent symptoms despite the fusion. So we do the endoscopic navigated, as I said, using navigation, removal of the odontoid. So what we decide to do, transoral endoscopic. Transoral, when you don't have clivus hypoplasia and the odontoid is not so high, you have access to the body of the axis, and you can use reconstruction techniques, but the surgery is much more morbid than you go endoscopic. So, as I said, this is not so common nowadays. We decrease the use of this anterior approach, but we still have some scenarios that we have to, especially in cases that were not properly fixed or reduced by a posterior approach. And this case was sent to me for a odontoidectomy. It was a tumor, and you see that the odontoid is compressing the brainstem. But what we do, it is some traction, and after some traction, it reduced. So I do only posterior. It's a very fragile patient. So you have to be careful before do anterior approach, because we know that it was a spinocellular tumor. We know that the patient is fragile. So you do anterior and do posterior. So try to do only one. So make sure that you are choosing the best approach for your patient. It's imperative, as I said, that you flip and fix your patient in the same surgical scenario or early. If you decide not to do an occipital fusion, put him in a halo or in a rigid cervical collar until you fix. Oral feeding can be immediately in endoscopic, but in oral transoral, I don't have case that I give oral feed immediately. Most of the times it takes some time because, as I said, there is some swelling in the tongue, and you have to have a careful extubation. As I usually ask for the ENT team to look at the mouth and to make sure that don't have edema. We have a cadaver course that we train in this with the residents, and it's very nice to training the removal of the C1. So anatomical knowledge is important. You have to go to the lab to look at for the joints before do this in a live human being. We have to work together with the skill-based and ENT. They teach us a lot, and they help us to take care of the patient after surgery. That's pretty good, especially because we have very limited care in the mouth. I don't use transoral odontoidectomy as a routine. We do less cases because of the powerful posterior techniques, but we still have some indications in the same for transnasal endoscopic. And if you use the posterior techniques well, you don't need to do anterior in most of the cases, and it's pretty good for your patients. Thank you so much for this opportunity.
Thank you, Professor. That was an amazing talk, and something that certainly the younger neurosurgeons can use to aspire to.
Thank you, Dr. Tanya.
Have we got Professor Goel online?
Yes, Prof is online.
So Professor doesn't need any introduction. He is a leading figure in global neurosurgery, particularly in the craniovertebral surgical region, as well as skull-based pathology and complex spinal stabilization. He is Professor and Head of Department of Neurosurgery at the King Edward Memorial Hospital and the Seth GS Medical College, Chief Neurosurgeon at Tata Memorial Hospital and Cancer Research Institute in Mumbai. He's on the editorial board of the Journal of Neurosurgery and a number of other reputable surgical journals. He is a nationally lauded teacher of medicine, vice president of the Asian Society of Neurosurgery, past president of many other societies, and more than 800 articles in peer-reviewed journals. We can go on and on. But here is the name is Professor Goel. He's going to be talking about posterior approaches to the craniocervical junction. Thank you, Professor.
Thank you, Tanya. Can you hear me, Tanya? Because, little bit, I'm not in my familiar location. Can you hear me?
Yes, we can hear you loud and clear.
Okay, now I hope you can. Can you see my video? No. Can you see my screen? No.
Sorry.
Can you see my screen, Tanya, or no?
Yes. Can you?
We are seeing your desktop, Professor.
No, actually,
Yeah.
just a minute.
You drag the Zoom meeting down. Have we still got you, Professor? Well, in the meantime, whilst we're waiting for Professor, shall we see if there's any questions? I'll have a look at the chat. Does anyone have any questions in the participants? I'll just wait to see. Oh, yes.
Yeah.
Jessica Shashan.
Dr. Igal, you need to unmute.
You have to unmute.
Now it's better?
Yes, thank you.
Yes, that's a question for Andrei. Thank you for your two talks all the way from Sao Paulo. I'm Egan from near Jerusalem in Israel. Regarding your first talk about the anterior screws for odontoid fractures, I understand that you use the biplanar scope. And my question, when we educate the new young generation of spinal neurosurgeon, would you recommend them to be more aggressive in front of the management of the hospital to acquire a navigation system with whatever intraoperative imaging modality that is available now in the market?
Well, that's a very, very good point. I think the new generation will be more navigated based than the middle and the old generation, and because we don't have these devices in the past, so we have to use the fluoroscopic and the conventional radioscopic. So I think they should fight for this kind of equipment that makes surgeons safe and fast, for sure. But what my point is that I can talk about brain surgery. You can have a navigation, but you still have to know anatomy, because tools not every time they work it well. They are 100% sure that you are doing. So of course it helps. Of course we have to try to get this 3D arm, CT arm, and the O arm and navigation systems, but we still need to do understand the anatomy, and because if you are working then and there's a problem in the navigation or there's a problem in the 3D arm, what do? You stop it, you don't operate it. So
you call your old chairman from home.
yeah. Well, there's a history. I don't know if it's true that people are doing a lot of robotic surgery and then they have important complications and they have to get the old surgeons because they don't do open surgery anymore. So my point is that, of course, we have to go on. We have to acquire equipment and technology, but we have to have a strong basis. If you have a strong basis, you can have technology as well.
Thank you.
Can I ask Dr. Andrei? There's contraindication for screw old fractures. But what is the age of fracture? What is the old fracture means?
Yeah, old fractures, they don't heal because when you do a primary osteosynthesis, you cannot have a pseudoarthrosis. If you have already some fibrous tissues, it doesn't fuse. So it's recommended for acute odontoid fractures only.
Okay.
Thank you, Professor. Is Professor Goel online now?
Yes, Prof. Goel.
I am hearing just there is some issue here. What's that? Sorry.
Just click on enable content. Dr. Atul, just click on enable content.
Okay. एक मिनट शेयर करोगे शेयर अभी ये करो enable content please share this one. Can you see? No, I'm having some problem in sharing. Stop share. Stop share. This one, right? Sharing. You can see now?
Yes, we can see your desktop. Can you?
Yes, now I can see. Okay.
Yes.
Here we go.
First thing is, I'm really sorry because this is not the familiar place where I'm doing this presentation. This is a very unfamiliar place, and with great difficulty, I have been able to join. Whatever said and done, I'm very happy. You can hear my voice properly, Vincent?
Yes.
Yes.
No, I am talking on a very favorite subject of mine, and that is craniovertebral junction. And many of you know that I have been in this junction for last 35, 40 years of my very small little life. And I want to share some thoughts on this life of mine. Craniovertebral junction surgery is absolutely complex. It is not only complex, it is absolutely dangerous. These kind of complex situations, if you treat them properly, you can just not only turn their neck straight, but you can give them new life. On the other hand, if you don't treat them properly, you can make them demolished. You can kill them, or you can have a situation where they don't live and they don't die, and they will not let you live. So it is a difficult situation. And what we require is proper understanding of anatomy, proper understanding of mechanics, and most importantly, we have to understand the philosophy. And if we understand the philosophy, we can really make fantastic kings out of our patients. We can give them beautiful smile. We can give them beautiful life. And if you ask them after operation, have you got a new life? The answer will be positive and very affirmative, yes. So that is, you can change the life. And in my life of neurosurgery, I have been fortunate that I have been getting many such patients from all over the place. And I want to share with you some of my experience in this field. So craniovertebral junction is like a pillar of spine. The upper part of the pillar to give stability to the roof is bifurcated. Similarly, the upper part of spine is bifurcated. And this bifurcation has two joints, occipito-atlantal joint and atlantoaxial joint. Occipito-atlantal joint is the center for stability of the spine. Atlantoaxial joint is the center for mobility of the spine. So mobility and stability are the hallmarks of craniovertebral junction. And of course, they have to be absolutely perfectly aligned and poised to stabilize the head on the neck and to keep the neural structures intact. This is the majestic atlantoaxial joint. It is special joint, special vertebra. The arch of Atlas is here, which is not there anywhere else. Transverse process is the largest of all the entire spine. Spinous process is the largest of the all spine. Facets are the strongest of all spine. So this is an odontoid process which is unique. So it has many unique structures. Most important is if you see this vertebra, the superior surface of Atlas, there are many sites for ligamentous attachment. It is a very, very strong joint, occipito-atlantal joint. On the other hand, atlantoaxial joint, you see the smooth and round joint. It gives circumferential movements to atlantoaxial joint. Most important is, you see there are hardly any ligamentous attachment. More the mobility, more the potential of instability. So atlantoaxial joint is the most unstable joint of the body, and occipito-atlantal joint is the most stable joint of the body. Facets, all the movements happen in the facets, and facet is the point of movement and fulcrum of all movement. So I had described this C1, C2 technique. Many of you or most of you know this technique. One screw in C1, one screw in C2, and this stabilizes the facet. This stabilizes the point of movement, and there is no question this is the strongest technique of atlantoaxial fixation. So since 1988, I described this technique in 1988. My technique involves opening of the joint, removal of the cartilage, and putting bone graft in the joint. I think these three steps are absolutely important in my technique. And once I do these three steps, then I put the metal plate and screws. As I mentioned, occipito-atlantal joint is the strongest joint. Occipito-atlantal instability is the most uncommon instability. I used to do occipito-cervical fixation. Occipito-cervical fixation very frequently in my life. And I described occipital screws for the first time in the literature in 1987. But now as I move on in this business, my feeling is, the question is inclusion of occipital bone in the fixation construct necessary? Second question is inclusion of the occipital bone in the fixation construct a counter-effective phenomenon? So now I feel craniovertebral junction instability is equal to atlantoaxial instability. Craniovertebral junction stabilization is equal to atlantoaxial stabilization. And inclusion of the occipital bone in the fixation construct is less than most optimum form of fixation. So we should not include occipital bone in majority of cases. Of course, in extreme degree of trauma, when there can be occipito-atlantal instability, or in some syndromic children where there can be occipito-atlantal instability, in general, the principle is clear. Occipital bone should not be included in the craniovertebral junction stabilization. So this is a huge statement I am making. And most of the people interested in craniovertebral junction surgery include occipital bone, and that is easier method, but longer screw, longer implant, suboptimal stabilization. So you should aim at C1, C2 fixation. So facets are the issue. Facets can become oblique and all those things over the period of time. instability is the problem, and stabilization of C1, C2 is the issue. So this is my first case I did in 1988, one screw in C1, one screw in C2. You can imagine 1988 means more than 35 or 37 years ago. And you see the occipital, there is no inclusion of the occipital bone in the fixation construct. It is just atlantoaxial fixation. And over the period of time, I have done more than 4,500 fixations like this. And I have a feeling that this number is certainly very big in parlance of craniovertebral junction stabilization. But this is what I have enjoyed, and this is what I have done. The technique can be done in children. The technique can, this is a 1 year, 6 months old child. It can be done in very old people and things like that. So this is another very small child where atlantoaxial fixation is done. You can imagine there is opening of the joint, there is bone graft in the joint, and then there is fixation, and then there is bone graft placed posteriorly. So as far as the screws are concerned, facets are concerned, and atlantoaxial instability is concerned, these three things were not very common in neurosurgery. In neurosurgeons did not know what screws are, did not know what facets can be, how facets can be used for fixation, and atlantoaxial instability was also not very frequently done in 1988 I'm talking about. So these things have to be understood, these things have to be learned by neurosurgeons, the mechanics of screws, mechanics of plates, and things like that. Another very beautiful thing that we did early on in 1988-89, the understanding of C2 ganglion. If you see, the C2 ganglion is placed right over the atlantoaxial joint. So we did C2 neurectomy, cut the ganglion and open the joint. This was what I did in 1988. But of course, now I do ganglion resection very infrequently in my picture. I can mobilize the ganglion up and mobilize the ganglion down, and then do C1, C2 fixation. But this opened the window to atlantoaxial joint. The pedicle of the C2 can be divided in 9 quadrants. The uppermost quadrant, this is what I described in 1988 when the CT scan were not so good, coronal images were not so good, and the MRI was hardly in place during that time. But we described these. This is my picture from 1988. We said that the upper and superior and medial quadrants are the strongest points and the safest points for vertebral artery to save the vertebral artery. So the C1 screw is not an issue. You can put, because it is large and round and vertebral artery is not an issue. C2 screw has to be medial and superior. That is the most critical. And I will like to talk a little bit about C2 screw placement. Needless to say that if you can do this fixation, not only you give a radiological beauty, but you can give a clinical beauty, which is just hard to imagine. It is hard to believe that you have given a new life, and this new life is here to stay. So those who are interested in craniovertebral junction surgery must know this position. My feeling is this is a most beautiful position. This head is a little bit high and under traction. The head is not even touching the headrest. It is floating head, and little bit head high position reduces the venous congestion, which is a very critical issue in this area. I used to sometimes use navigation to put my C2 screw, but I hardly use navigation. But I recommend that those who are new or not so much familiar with C2 screw insertion should use navigation to put the screws. Another very important thing that you must know is the craniovertebral junction is most mobile because there are huge muscles attached. And when you have done the fixation, you have to cut the muscles attached to the C2 spinous process and to the arch of atlas, because they can move. You know, these muscles are so strong that they can break any implant. So after your surgery, you have to cut all the muscles attached to this. This is also one very beautiful and very important technical step, that you have to cut the muscles, and then you have to drill the posterior sub, decorticate the arch of atlas, decorticate the lamina, and then put a lot of bone graft in the midline. So there is bone graft in the joint and bone graft in the midline. So what we want to do is ultimately we want bone fusion, and this bone fusion can be done if you have prepared the host bone properly, and also you have put a lot of bone graft. I always use iliac crest bone graft in my life of craniovertebral junction. I have never used any other bone graft like rib graft or artificial graft. So one screw in C1, sometimes you can use a Magel's technique. This is Magel's technique, which is transarticular. So sometimes if in difficult and complex situation, I use this double insurance kind of fixation. I'm not using it regularly, but can be used. It gives additional stabilization. So this is the situation. You have one screw in directly in C1, one screw in a transarticular fashion. As I have said, the vertebral artery in the C2 is the critical issue. Vertebral artery goes medially, and then you see this is the articulation. Sometimes this is, of course, it does not go so much medial, but this medial loop of the artery is the most critical issue when you do C2 screw fixation. So you have to know when you are putting C2 vertebral screw, that is the critical point. This is abnormal vertebral artery. It is coming out like this and going behind the facet, atlas facet. It does not go like this. It goes above the arch of atlas, even in the assimilated situation. But you see, this is a 3D model. And this 3D model, you see the vertebral artery here. You can clearly see the vertebral artery. You can design where you have to put the screw. You can identify the joint. You can put the screw C1, C2. So always, so bottom line for me is in my 40 years of skull-base surgery and craniovertebral junction surgeries, always C1, C2 screw. This is the problem, and this is the solution to stabilize C1, C2. So these three-dimensional models are very good. Another beautiful point I want to show you is, this is the superior facet. This is the beauty or majestic C2 vertebra. This is the superior facet of C2 vertebra. Normally, in all other vertebra, the facets, the superior and inferior facets are in alignment. They are one rock. But C2 has a very unique composition. This is the superior facet, and this is the inferior facet. So superior, we want to put the screw like this in the pedicle and in the facet, but sometimes this vertebral artery can be a problem. So you can use the inferior facet also. So this is one point that we have found very useful. Of course, you can use laminar screws and spinolaminar screws, but inferior facet screws can also be used. So just see this. Here is the inferior facet. This is the superior facet. This is the pedicle. One screw in C1 and one screw in the inferior facet, which is very strong. And you can go, if you wish, in a transarticular C2-3 fashion. So this technique we have published, and I'm very happy and very comfortable. I use it very rarely, let me tell you. I always use C2 pedicle, C2 facet screws, but rarely I use inferior facetal screws. So this is one more case like that. You see there is very high riding vertebral artery in the superior facet. Inferior facet is quite virgin. So I put one screw in C1 and one screw in the inferior facet. So believe me, this can also give a very strong purchase. Of course, you have to open the joint. Of course, you have to put bone graft in the joint, and you have to put a lot of bone graft behind the posterior elements of C2 and C1. This is another case. You see very high, the vertebral artery foramen is quite in a difficult situation. So what I have done is one screw in C1 and one screw in inferior facet of C2. So you please remember that this inferior facet can also be a useful place to put your screw. Other thing is, you see this vertebral artery has a lot of venous plexus around it. So when you move your neck, the vertebral artery moves. So it is a dynamic process. And during surgery, we describe this mobilization of vertebral artery. So the bone can be very thin here, and you can mobilize the vertebral artery and put your screws in C2, of course C1. So here you see the vertebral artery is very high. So what we have done is mobilize the vertebral artery down and then put the screw in the C2. This, believe me, this is not necessary most of the time, but if necessary, you can use it, this technique of mobilization, because it is not at all difficult. It is a little bit technically challenging, but you have to, when you are doing a complex surgery, challenges have to be faced and have to be monitored and have to be overcome. Another thing that we described long time ago, about 25, 30 years ago, screw implantation in the spinous process. In the spinous process, in the spinolaminar line, and in the laminates. So this I described in 2004, so 21 years ago. So you can put occipital screw and this in the spinous process and in the spinolaminar. I must say, I have not used occipital screws for last 20 years, and I have not used spinous process and spinolaminar screws for similar 20 years. I use only C1, C2 fixation, extremely uncommonly occipital fixation. We also describe intrafacetal spacers. So you can use the spacers and jam it into the articulation and can be used as a standalone fixation. But essentially what we describe them as distractor for cases of irreducible atlantoaxial instability and basilar invagination. So, but rarely, I have to also tell you, I described these spacers 20 years ago, and I hardly use as a standalone fixation technique, but can be done. Another thing I have to show you is, as I mentioned, occipital screws and occipital plate or rod, I hardly use. In difficult situation, I do a small little craniectomy and transcranial insertion of atlas fascial screw. Now here is the, you see, it is very high atlas facet. More often you can expose it from the lateral gutter, but if not, you do a small little craniectomy here and go extradural and put your screw here, like in this case. You see, it has been, there is a small little craniectomy over the facet and then the screw. I have to also tell you, although this technique is possible, but I rarely at all, if at all, I use it. So there can be vertical instability. You see, there is inflection, it goes down like a piston. In extension, it comes down up. So there can be vertical and reducible atlantoaxial instability. There can be, following trauma, complete disruption of the atlantoaxial joint. So we had described a technique of manual manipulation of facets. Open the joint and manually manipulate the facet and realign the joint. So this technique, of course, is very popular technique in craniovertebral junction. In bifid spine, there can be lateral dislocation. You see lateral dislocation of the facet. When there is bifid, when there is trauma to the arch of atlas, when there is rheumatoid affection, there can be lateral dislocation. The most important advance in the craniovertebral junction surgery, or I will say a revolution in craniovertebral junction surgery, was about 20-25 years ago, when we said that there is nothing like irreducible dislocation. So there were two types of dislocation. One was irreducible and one was mobile. For mobile, atlantoaxial fixation was the treatment. For irreducible, decompression was the treatment. In 2001, actually, we described that there is nothing like fixed dislocation or irreducible dislocation. Open the joint, manipulate the facet. Those who are in the business of craniovertebral junction know that this concept has completely revolutionized craniovertebral junction surgery. No matter, we were doing transoral surgery, these kind of patients, inflection, extension, no change. The whole world was doing transoral surgery, decompression, but there is a possibility of opening the joint and realignment and fixation. So this concept has completely changed transoral surgery, and such surgery is very rarely, if at all, it is done. So open the joint, manipulate the facet. I used to put a lot of time intra-articular spaces, but now I don't put intra-articular spaces too often. Open the joint, manipulate, and put bone graft in the joint. More important point is when there is dislocation, instability is the problem. Realignment is the solution, but more than realignment, stabilization and solid stabilization and arthrodesis or bone fusion is the aim of surgery. So this kind of huge dislocation, which is fixed in flexion and extension. So the treatment is not decompression. Open the joint, manipulate the facet, and realign the craniovertebral junction. Another very important advance in craniovertebral junction is for rotatory dislocation. Rotatory dislocation, there was no treatment for rotatory dislocation. The whole world used to put some halo traction, and some people had advised decompression. But if you open the joint, manipulate the facet, realign, you can give beautiful smile and beautiful neck to these people. And you see this kind of rotatory dislocation, and this can be instant in the evening of operation. The concept of opening the joint, manipulation of the facet has completely, you see the odontoid process can come in the midline and fixation. Another thing is about basilar invagination. Basilar invagination we had described of two types. One is odontoid going up, and the second is tonsil coming down in 1988. And this paper is quite highly recognized paper, group 1 and group 2. For this group, we had advised transoral decompression. For this group, we had described foramen magnum decompression in 1988. So my own treatment was decompression. But in 2004, we said the group A does not need decompression. It needs realignment and stabilization. We thought instability is the issue here. But in 2004, my treatment for group B was foramen magnum decompression. So I divided into unstable and stable, stabilization and decompression. This is what I described in 2004. So this kind of basilar invagination, open the joint and realign the craniovertebral junction, distract the facet, this treatment for no decompression. So basilar invagination, no decompression, basilar invagination, and we have now got hundreds of patients where we have not done transoral surgery at all for any case. And sometimes if the realignment is not complete, that does not mean you do decompression. If your stabilization is solid enough, you don't need any kind of decompression. So instability is the issue and stabilization is the treatment. That is my concept. So realignment and stabilization is the treatment for basilar invagination. And as you are seeing some representative cases. And as I mentioned, transoral surgery was my favorite operation. And I used to do transoral surgery all the time. And I have got huge experience. But for 20 years, no transoral surgery in my department. For the first time, we described transoral metal plating. But of course, this was history. And this history has never been repeated in my department. So transoral decompression surgery is completely historical in my operation. Now, before I leave you, I want to give you another huge revolution in craniovertebral junction surgery, and that is the concept of central or axial atlantoaxial instability. When there is chronic instability, long-standing instability, injury during the fetal life, injury during the neonatal life, there are several secondary reparative natural mechanisms. Like we call these mechanisms pathological, like Chiari malformation, syringomyelia, basilar invagination, and all these things we call them pathological. But what my concept is, and this concept is based on several patients now, that atlantoaxial instability, chronic instability leads to several secondary alterations. Like I will just try to explain what is central instability. In 1999, I said that basilar invagination is nothing but listhesis, like lumbosacral listhesis, C1 over C2 listhesis. This is what is basilar invagination. So in this case, there is Chiari, there is syringe, there is listhesis. You see, there is listhesis. The treatment is realignment, treatment is stabilization. There is no role for decompression. This is what I described in 1999. And this is another case where there is basilar invagination carry. There is a problem. Listhesis is the problem and stabilization is the solution. Now I want you to carefully look at this slide. Now here, this is listhesis of C1 over C2, the cause of basilar invagination. Instability is the issue and stabilization is the treatment. Nobody used to do stabilization for basilar invagination 25 years ago. Only treatment was decompression. And this was in 2000, a complete different version for craniovertebral junction surgery. Now, I want you to see this slide. This is basilar invagination. There is no atlantodental interval disturbance. There is carry and there is syrinx. The whole world will do foramen magnum decompression for this situation. But if you see the facets, there is retrolisthesis of the facet. And this indicates unstable spine. This patient does not need decompression. This patient needs stabilization. So this is a huge, huge concept in craniovertebral junction surgery, that this kind of basilar invagination, where I recommended foramen magnum decompression, the treatment is stabilization. Now carefully look at this slide. The facets are in alignment. There is assimilation of atlas. There is syringomyelia. There is carry malformation. My concept is now clear that basilar invagination, assimilation of atlas, carry malformation, syringomyelia, platybasia, all these are secondary. All these are protective. All these are reversible following atlantoaxial stabilization. And if somebody has any kind of doubt, please don't have doubt. My experience goes beyond 600 cases where we have done only stabilization for all these problems that you are seeing. Just carefully look at these slides, my dear friends. C2-3 fusion. If a patient comes with C2-3 fusion, the problem is unstable atlantoaxial joint. If the patient comes with carry, the problem is atlantoaxial instability. If the patient comes with basilar invagination, problem is atlantoaxial instability. Bifid, os odontoideum, and this is only a very small list. There is a bigger list. So atlantoaxial instability is the father, and all these are secondary. All these are children of atlantoaxial instability. They can be present if only carry can be present, or carry can be present with basilar invagination, or only basilar invagination can be present, or only syringomyelia can be present, but they all indicate atlantoaxial instability, and they all indicate the need for atlantoaxial stabilization. So basilar invagination, the issue is not compression, issue is not deformation, issue is unstable atlantoaxial joint. For group A and for group B, both these groups, you need only one treatment, and that is a solid atlantoaxial stabilization. Open the joint, manipulate the facet, denude the cartilage, put bone graft in the joint, and then do C1, C2 fixation. You have to just believe me, you give a new life instantly. But these are difficult operations and we have to learn them. So facetal realignment, you see there is a facetal instability. You don't have to do decompression in such cases. Huge basilar invagination where I had recommended foramen magnum decompression. Even if there is no facetal malalignment, you have to do for this kind of no decompression, you have to do C1, C2 fixation. Another thing I am telling you, no occipital fixation you will see in any of my slides, except for the initial slides. So basilar invagination, even if the facets are in alignment, even if when there is no atlantodental interval disturbance, even when there is no evidence of compression, you have to do C1, C2 fixation. Carry, when there is carry, when there is syringomyelia, when there is basilar invagination or no basilar invagination, when there is facetal malalignment or no facetal malalignment. Now we have got different parameters to identify unstable atlantoaxial joint. The treatment is atlantoaxial stabilization. Syrinx will reduce in 100% of patients. More important is The patient will get in the evening of operation, believe me, my dear friend, in the evening of operation, the patient will say, the family will say, the father and the mother will say that the child has got a new life. The hand, the tingling paresthesia in the hands will go, the weakness will go, spasticity in the legs will minimize, voice will change, and most importantly, when you ask them, have you got a new life? This is my question. I have got more than 500 audios on my phone where I am talking to the patient. Have you got a new life? And the answer is yes. So this understanding is a complete revolution in craniovertebral junction surgery. So there is no bone abnormality. You see, there is no atlantodental interval disturbance. There is no basilar invagination. There is no facetal malalignment. There is no compression. Do fixation, the syringe will reduce in 100% of patients. Whether the syringe will reduce or not, that is not the issue. Patient will say, absolutely magical new life. So basilar invagination, syringomalia, Chiari formation are all secondary to chronic atlantoaxial instability. So if you have time, my dear friends, please, and if those who will be really interested in craniovertebral junction surgery, this article I had written about 5 years ago, and as I have mentioned, now my experience is beyond 600. No question, no doubt, patients where we do foramen magnum decompression, they need C1, C2 fixation. And decompression, in my view, is a negative operation. Chiari is not a malformation, it is a natural protective phenomena and a natural response to chronic atlantoaxial instability. Similarly, clipal file abnormality, assimilation of atlas, C2-3 fusion are all secondary to chronic instability. You see, there is no compression at the C1, C2, but it is unstable. Don't do any kind of bone decompression. This patient was hardly able to breathe before operation. And you see the dynamism on the face in the immediate post-operative. And you have to only believe that I gave a brand new life to this young little girl. You see this kind of bone fusions, this kind of massive, don't start doing decompression of the syringe, don't start doing foramen magnum decompression, don't start doing transoral decompression. Learn the art of C1, C2 fixation and and get familiarized with this kind of smile from the patient and this kind of proud feeling of the doctor. Difficult operation. So when you see C2-3 fusion, there is C2-3 fusion, there is compression here, but don't worry about this compression. It is atlantoaxial instability and atlantoaxial stabilization. So C2-3 fusion, assimilation of atlas, clipal file abnormality are all indicators of unstable atlantoaxial joint. So when you see C2-3 fusion, even if there is a huge cord signal here, don't worry about this cord signal. You do C1, C2 stabilization, and you have to only believe me that you have created a magic in the life of the patient. When you see this kind of C2-3 fusion, when you see subaxial compression, you don't have to worry about subaxial. Another thing that you see is, there is extra CSF around the cord. There is syringomalia here. There is clipal file, there is Chiari, and you have to do, no question, C1, C2. There is compression here, there is C2-3-4 fusion. No question, you have to do C1, C2 fixation. Bifid is another natural protective phenomena of chronic instability. When you see bifid, when you see bone fusion, you don't have to see anything. You have to just do C1, C2 fixation, and you are there to give a fantastic neurological recovery. Similarly, os odontoidium, whatever sentences I am saying are all published. When I say it is natural protection, it is published. When I say it is divine phenomena, it is published in my article. So you don't, I'm not just saying what I'm saying, but it is all published. Os odontoidium is a protective phenomenon. When you see os odontoidium, don't see anything else. Just do C1, C2 fixation. Don't start fusing occipital bone. Don't start fusing subaxial C3, C4, C5. I have seen many patients occipital fixation and all. And most importantly, don't start doing decompression which is an absolutely negative phenomenon. Syringomyelia, as I have said, is another child of atlantoaxial instability. When you see,
sorry to
when you
interrupt, just in the interest of time.
yes, just last few slides. So when you
Great.
see only syringomyelia, you have to do fixation. When you see short neck, when you see torticollis, it is indicator of atlantoaxial instability, and you have to do stabilization. So you can make this kind of majestic outcome. The concepts have to be understood, concepts have to be learned, and concepts have to be deciphered. And my dear friends, I have to say that foramen magnum decompression surgery is now, in my view, completely historical operation. I'm sorry, Tanya, for a little bit longish. I become a little bit more excited when I talk on this subject, but these are my views. Thank you very much.
Thank you, Professor. That was fabulous. So much passion in your talk. We do have a couple of questions. One is from Stefano Conti. In the setting of basilar invagination and Chiari malformation after C1-2 fixation, in which case is better to do foramen magnum decompression?
Foramen magnum decompression in basilar invagination, in Chiari malformation, in my view, is a completely negative operation. So that is one, in my view. Second thing is, when there is basilar invagination alone, or when there is basilar with Chiari or with syrinx, the treatment is only one, and that is atlantoaxial stabilization solid. And there is no question in my mind about the validity of this operation and the beauty of this operation.
Professor, just going on from that, for those surgeons that do a foramen magnum decompression, for Chiari malformation, would you expect, if there's instability, would you expect in the long term that there is a recurrence or, further instability if we
Yes.
if those surgeons don't fuse? Because it's
yes,
not commonly seen, I guess.
Let me answer that question, Tanya. This is a very, when you do your next patient, when you get of Chiari, you first thing that you do is see the muscles of the neck, and you will find these muscles tight. You ask the person to move the neck, the movement will be restricted. Then the next question that you ask is, in a little bit older child, not in a younger child, is the voice changed? And believe me, in at least 50% of the patients, the mother or the father or the patient will say that the voice has become little bit high, low tone voice. Then the next question you ask them is, do you get sleep apneas? Next time you ask your patient, at least 30 or 40% of patients, they will say they have got sleep apneas. The next patient that you see, you ask in which position they sleep. They will not sleep in supine position. They will sleep in lateral position because there is a hump in the back, little bit more than normal, and this lateral position is more comfortable for them. And what I'm saying is, you do C1, C2 fixation in the evening of operation. I'm not saying after 2 months or 3 months, they will say the voice has improved. And the first thing he said that I have not slept supine for last several months, and the whole night today I have slept supine. So this is the beauty. More than that, they start breathing properly. Their voice becomes better. And other symptoms, Now, the question that you asked me is, in foramen magnum decompression, there will be delayed kind of instability. Now, when I used to do foramen magnum decompression, I used to tell my patients that you will not improve in following my operation, but I am doing this operation to stalling the symptoms. They will not progress. This is what I used to say. Now I have, for 20 years, I have not done any foramen magnum decompression. But here I'm saying you will not only improve, you will get a new life, I can say with great confidence. Another thing is, I said about syringomyelia will reduce in 100% of patients. if you do a scan after 6 months, syringomyelia will reduce in at least 50% of patients if you do a scan after 5 days. To that extent, I am saying. The thing is, if you have done decompression in an unstable situation, like I'm saying atlantoaxial joint is unstable, and you have done decompression, these patients are bound to, the progression has to be, initially when you take muscle stitch and there is some pain after surgery, they will say, yes, doctor, I'm a little bit better, a little bit tingling is gone and all those things. But after 1 month or 2 months, in my view, 100% of these patients will continue to have symptoms, and many of them will have persistent and develop major symptoms. Now, in my practice, most important cases which I am doing are failed foramen magnum decompression. Even where I had done foramen magnum decompression, I am now doing C1, C2 fixation. So, Tanya, that is the answer to your question.
Thank you. There is a question from Dr. Punya who said, role of the O-arm, question mark. So in other words.
Yes, role of O-arm, yeah. See, as I have told you, I am doing this operations in 1988. I used to use navigation when this instrument came new in my department. I started using navigation. It is useful. I am not saying it is not useful. But now I am not using any navigation, any O-arm or any C-arm or anything. Most important is you have to have confidence, but you cannot have pseudo-confidence, because if you damage the vertebral artery, it can be a very major issue. So I will say that if you can have navigation, particularly when you are not extremely familiar with this situation, you must use navigation. I don't use navigation now for last several years. I must tell you another thing. Occipital screws I had described first. I don't use occipital fixation now at all. Another thing I will tell you. The concept of tight posterior fossa in Chiari malformation, I had described in 1998 in Journal of Neurosurgery. You read my article. I had said the posterior fossa becomes tight and you do only bone decompression, that is good enough. I had described, but now I am saying I don't like it. I don't want to do it. Third thing I had described is various transoral procedures I had described. But now today I am saying transoral surgery is a completely, absolutely not necessary operation. Of course, in chordomas and tumors, that is a different entity. That is not the thing that we are trying to address today. That is the situation, Tanya. Vince, I want some, Vincent, your face is constantly on my screen. I want you to ask me some questions.
Does anyone else have any questions? We should wrap it up soon.
Dr. Sinha has a question.
Oh, Professor Sinha. Can you unmute yourself? Can you unmute yourself?
Yeah.
Before you unmute, let me tell you another thing. You see, in the presence of basilar invagination, in the presence of Chiari malformation, in the presence of syringomyelia, the C1, C2 fixation can become a little difficult and tricky operation. It is not as simple as that. It is a little difficult because the venous in syringomyelia, there is huge extradural venous because the cord is very flabby. In basilar invagination, C1-2 articulation is very rostrally located, so you can have difficulty in exposure. So these are difficulties, but when we land into the subject of craniovertebral junction, we have to not only learn the difficulty, we have to address the difficulty. If there is some problem happens, we have to know how to overcome that problem and go further in the business. So these are difficult, but you must remember, there is a big potential to give a new life. And that beautiful new life, you cannot imagine the faces of these patients, the faces of the mother and father. This is new life. And for this new life, we have to learn this difficult technique in difficult situation. And decompression is an absolutely rubbish kind of operation. I'm sorry to use this word.
Dr. Atul, excellent presentation as always you do. Just I want to ask, still you do the customized 3D printed models for CV junction?
Yes, yes. This is another one which I know Dr. Sinha is also very much familiar with this, and they have also done a lot of 3D model printing in craniovertebral junction surgery. But I described this long time ago, 3D model. But nowadays, you know what? The issue is, Dr. Sinha, I am having, whether I am lucky or whether I am not lucky, I'm not sure, but I am getting every day I'm doing such patient. You know, I'm doing more than 250 or more C1, C2 in 1 year. Can you believe that number, or it is difficult for you to believe that number? So that has to be believed, and that has to be, you know, that with that number, with that experience, nowadays 3D models are not very frequent in my series. But they are beautiful investigation for the person who is trying to learn the technique. You know, he has to, 3D models are miracle, and they just make life very beautiful and simple.
Yeah, I learned with this technique.
Oh, Professor, if we had more time, we could talk about this all night with you. Very much appreciative of your participation in this webinar, and also Professor Joaquim, and also Dr. Sundar. Beautiful presentations for all three of you. Much appreciated. If there's any
Thank you so much.
Thank
anyone
you,
else?
Andrei. I can see you, my dear.
Hi, Professor. Good to see you.
How are you, Andrei? Everything
I'm good,
okay?
and you? And everything okay?
Thank you, and have a good weekend, everybody.
If anyone's
Have a
got
good weekend.
Thank you.
come offline.
Description is also there.
Thank you very much.
Thank you.
Thank you. So for all those who will want to review this, you can watch it on the YouTube Live or LinkedIn Live. The entire video sessions are being recorded. Thank you, and I'll close the seminar. Thank you, Professor.
Thank you, Vincent.
Thank you very much. Thank you. Thanks.